me. I see a lot of people from the LGBT community. That's a big part of my practice, actually. And so now we're starting to see some people, particularly probably one of the most difficult situations is a trans man or somebody that now has had a reconstruction where they have a reconstructed penis. Now, that's not a real penis, of course. And that could either have come from tissue from their arm, it's called a radial forearm flap, or if they have enough fat and tissue on their anterior thigh, that can be used to kind of reconstruct a phallus, also a scrotum, believe it or not. And it's not a very, very common procedure, but what has developed has been the requests for placements of penile prostheses into these reconstructions. That's something that I've been confronted with. It's certainly not something that I couldn't do. It's certainly not something that I heavily researched. And, you know, if someone's gone through the trouble at this point of that reconstruction, you know, there's no reason for them not to want to go all the way and have the ability to have an erection. And penile prosthesis is how people that don't have erections get erections. And certainly this is what we do in normal penises. The problem with putting a penile prosthesis, not that it's not doable, into a reconstructed penis is you have to understand, how does a penis work? A penis is like a triple-barreled shotgun, and the two top barrels are sort of these hollow, tough cavities that are attached down to your pelvic bones, and they fill with blood, and they get hard, and then they get soft. And a penile prosthesis is the act of kind of hollowing those out and then inserting your own inner cylinders that fill with water and not blood. Well, a reconstructive penis doesn't have those cylinders. Those are called corpora cavernosa. So the complication rate of that procedure is very high. It's upwards of, you know, anywhere from 30 to 50%. And there are some big complications. You've gone through this whole trouble of, you know, reconstructing this, and that has to stay alive on a artery from the original tissue. There's the risk of injuring that artery. That would be catastrophic. You don't really have a space for the cylinder that you're implanting. So you're kind of creating that space, and that could put constant pressure on the tissue, and it could erode. There's a risk of that with a standard placement of a prosthesis, but there's a very high risk of that in a reconstruction situation. And finally, these cylinders that we put in, you know, they're inside your own cylinders in a non-trans person that are then those cylinders, your own body attaches those to your pelvic bones. Well, in this case, you're just sticking a cylinder in there, and you're not really, it's not attached to anything. So of course you might imagine it'll migrate, or it won't stay in the penis itself. Everyone's got a different way of adhering the cylinder to the pubic bone, and they're all a little bit in development and fraught with complications. So, you know, I've concluded myself that I'm no stranger to doing hard surgeries or new surgeries, but probably these operations belong in the hands of those that are going to do these things over and over so they can keep modifying the technique. And I think it's probably also important that someone choose a surgeon who's local, because there is such a high complication rate that will require it being addressed immediately. And there's a very high risk of having to reposition the cylinder because it comes detached from the pubic bone, that I'm starting to help people by finding the appropriate person for them near their locale. But it can be done, but it's a tough case with a high complication rate.